Welcome back, everybody. I'm Sarah Emond. I'm ICER's president and CEO, and it's a real pleasure to be moderating this roundtable discussion. And I'm not lying when I say I've been looking forward to this roundtable for months. And I'm really thrilled with the group we've assembled to try to tackle some of the outstanding questions and issues that we have. Because today, during the roundtable, we might reflect a little bit on the votes that we just heard, some of the themes that we heard from the conversation of our independent appraisal committee. And I really want us to focus on what are the policy solutions in front of us to ensure affordable access. And I do want to emphasize what I emphasized in the opening of the meeting today. Now is a really critical time for our healthcare system. Affordability and access have never been more in jeopardy, and all stakeholders have a societal obligation to be part of a solutions-oriented discussion about improving access and affordability. And I'm so thrilled that we have all of the key stakeholders here today for that conversation. I also want to frame a little bit here. In some ways, the tension between great long-term value and short-term affordability is a great problem to have. It means that we're getting tremendous innovation out of the ecosystem for a lot of people. So while many ICER meetings talk about the limited evidence base, maybe some uncertainties around the long-term value, and sometimes questions about harms, I don't think that that's going to be a big focus of our conversation today. And I am not diminishing the clear questions that still remain for patients and their clinicians about appropriate use, but this is different. And the recent announcement last week, which I'm sure many of us were tracking, potentially a $245 a month price for Medicare and Medicaid for access to both of these medicines that we've been talking about today is notable as a watershed moment in this conversation about affordable access. But questions remain about the affordability of these drugs for the whole system. We're going to talk about that. We're going to talk about other policy options for ensuring affordable access to patients. And I do want to emphasize that I am excited for the energy that all of the roundtable members will bring to this conversation today, because I know that they're all thinking about the urgency with which we must all act in order to fix this tension. And so, as I let them introduce themselves, I think on the next slide, we have some important disclosures, and I'm going to invite each participant to introduce themselves. Please let us know if there's any update to the disclosures that are on this screen. After that, we'll take down the slide so we can see each other, and we'll be able to get into the conversation. Jason, could I ask you to go first, please? Not hearing Jason.
Sorry about that. Can you hear me now?
Yes, I hear you great, Jason. Welcome.
Thank you. Jason Brett, Principal Medical Head with Novo Nordisk here in the United States. And my disclosure is I am indeed a full-time employee at Novo Nordisk.
Thank you, Jason. Pat.
Hello, Pat Gleason, Assistant Vice President of Health Outcomes at Prime Therapeutics, a pharmacy benefit manager wholly owned by nonprofit Boost Plans in the United States. I'm a full-time employee at Prime, is my disclosure, as well as I'm an adjunct professor in the College of Pharmacy at the University of Minnesota.
Thank you, Pat. Alyssa, welcome.
Hi, thank you. Alyssa Gast, Associate Director of Clinical Pharmacy with IPD Analytics, which for those not familiar, we are a syndicated content provider that supports health plans, PBMs, manufacturers, health systems. Relevant to this discussion, I analyze and provide content surrounding payer dynamics, pipeline, market shift, everything with that in the obesity category.
Thank you so much, Alyssa. Melanie.
I'm Melanie J. I am a general internist and obesity medicine certified. I'm a professor at NYU. I do obesity research funded by the NIH and the VA. One of the conflicts that's not on here is that I've done like a few hours, like 3 hours of consulting for Novo a while back.
Thank you, Melanie. Joe.
Joe Naglowski, President and CEO of the Obesity Action Coalition. I think you see my disclosures there. The other one I added earlier this morning, and I'll add again now, is that I'm also a person who has used both of these medicines, currently on one of them.
Thank you, Joe. And Tracy.
Good afternoon, and thank you for the chance to join. Tracy Sims, Executive Director, Corporate Affairs, Eli Lilly and Company. No change to my disclosures.
Thank you, Tracy. Michelle? Not hearing Michelle.
Might help if I unmute myself. Sorry.
No worries. Thanks for being here, Michelle.
My name's Michelle Tedder. I'm a nurse and a patient expert, and I currently serve as the Director of Chronic Disease at the Black Women's Health Imperative, and and I'm a board member of the OAC. It's my only disclosure.
Thank you so much, Michelle. And Alexa.
Hi, I'm Alexa Trio. I'm a primary care physician as well as an obesity medicine specialist. And most of my work in the obesity medicine field focuses on empowering primary care doctors and really trying to create a supportive infrastructure for the system to deliver high quality obesity care to our patients.
Thank you for being here. I have deep gratitude to all of you for showing up for this conversation. And as I mentioned, I'm excited for us to focus on as many of the policy solutions as we can come up with for handling the tension between affordability, long-term value, this effective medicine. Before we get into some of the nitty-gritty on the policy options, on payer policies, how different stakeholders are thinking about this, I do want to center some of the themes that I heard in the conversation today around health equity. And we want to make sure that as we think about the policy solutions and talk about the pros and cons in just a moment, that we're not losing sight of some of the issues that might arise from some of those policy options as it relates to equity. I've got 4 themes that I want to hit on, but additional themes are welcome. I do want to hit on the idea of cost sharing and where we are with that, how that's impacting patient access, ways that we are making sure that's not exacerbating inequities. I want to talk about stigma and bias. I want to also reflect quickly on that one, just myself, that even in the 3 years since ICER did its first review in 2022, I have seen remarkable progress on this. Doesn't mean we don't still have work to do, but let's see what we can build on to make sure that we're addressing stigma and bias. The wraparound care for other comorbidities, that came up a lot today, and I'm putting it in the health equity bucket because there's additional stigma and bias for some of the co-occurring diseases and conditions that come with obesity that I think this is the perfect group to weigh in on. What are some of the solutions for those? And then I can't miss the opportunity to talk about direct to consumer. It is on everyone's mind. There seems to be a press announcement from the White House every week. But for me, it raises some important questions about equity. And I want to hear how Joe and Michelle's communities are thinking about that, how Novo and Lilly are thinking about that, and any other reflections we have. And so I'm actually going to start by putting Joe and Michelle on the spot. And Joe, I'm going to start with you. Let's take the cost sharing piece first here. When we talk about the grand bargain at ICER, we often talk about a fair price from a long-term value perspective being met with maybe little to no prior auth. Let's get rid of that, onerous prior auth, and then little to no cost sharing. Can you share a little bit about where you see some additional opportunities in this space for ensuring that we're not exacerbating inequities in the cost sharing piece?
Yeah, so thanks, Sarah, and thanks for including me today. And I think, one of the realities of where we are today is we make people with obesity and oftentimes their healthcare providers jump through all kinds of hoops and hurdles to access care, right? Kind of thing. And each one of those barriers, just adds another level and takes us around this equity process, right? Kind of thing. In fact, I will just tell you, in my own circumstance, for no amount of money can my organization buy insurance in the state of Florida that covers obesity care. So I go on my wife's health plan. There are hoops and hurdles I could choose to jump through on my wife's health plan to cover these medicines. And I choose not to engage in them because I think they ultimately will hurt me, right? I don't want to go to a specific provider who only handles my weight loss and doesn't handle my overall health, right, kind of thing. And so the reality is I stick with my primary care doctor, who's also board certified in obesity medicine, to do that. And fortunately, I'm of the means where I can pay $500 a month for my medicine, but that is not most people. And I think that's the reality of where we are now. Part of this, Sarah, and I've been working on this for 20 years now. Part of this is partially my own failure, right? My organization's failure over the years, because if we had 13 years ago convinced payers to start covering these medicines when they were, and at that time, less expensive and just coming on the market, not nearly as effective, obviously, but maybe we'd be in a different place today when it came to pricing and cost sharing. But we are where we are, and the reality is, though, it's a conversation we need to continue to have. And I'm pretty excited about what happened last week. Of course, the devil's in the details, but hopefully we'll start to see some of these prices becoming more reasonable, and therefore we can have a different kind of conversation, a conversation that's really about delivering the best care possible, not just delivering the cheapest care possible.
Jerry, appreciate that. I think you should let yourself off a hook a little bit. I know how the important work your organization has done on the stigma, the bias, the understanding of obesity as a chronic condition. I have learned a ton from you. And so, we often joke at ICER that since health insurance premiums are only going up, we're clearly also needing to do a little bit more for our part of that. It's complex. We all have a lot of work that we can collectively do. Michelle, why don't you share a little bit about how your patient community and what you are doing with the Black Women's Health Imperative and the cost sharing piece, anything that you want to touch on there from an equity perspective, please.
Yeah, I mean, I think that we're an example of a lot of diverse groups, right? So we serve people who are like me, who can access medications, can afford it through health insurance plans. Actually, ironically, not through my employer's plan, but through my husband's employer plan. But I think there's also we serve a lot of folks in the South and more rural areas, and that's a whole nother conversation in terms of accessibility. And then I think that if you start looking at um, across states and people being able to maybe access the medications through like the Affordable Care Act plans, that is quite variable depending on what state you're in. So, we see like the gamut of whether or not people are able to access it from an affordability standpoint. And in my own family, it took my son probably a year and a half to be able to access it because he doesn't have a commercial plan. He had a plan through the marketplace here in Pennsylvania, but it was not one that was covering. And so now, the conversation is, well, if the premiums go up, is he going to be able to afford that, next year? So there's a lot of buckets here in terms of how our community is able to access them. And then having such a diverse group of people from all over the country, it really is pretty difficult to kind of chase.
I think it's a bit of a hodgepodge, and we're going to get to Pat and Alyssa in a little bit from what the plan perspective is on trying to make it less of a hodgepodge while dealing with a very large eligible patient population. And so there's some math that's not mathing, what we might say a few times here, but we want to make sure that we're centering the ultimate affordability of patients when we think about these policy solutions. The other thing I just wanted to mention is both for Michelle's group, knowing a little bit about that group, and Joe's group, and ICER, the small nonprofits. Don't forget about us when we're trying to get affordable health insurance to our constituents. We have been dealing with some of the same issues here as our own organization. And the other part, thank you, Michelle, for bringing it up. We can't have this conversation today in isolation, just talking about these medicines. So, your son is potentially facing premium increases because of some choices that are being made on the federal level that are going to trickle down to some of the choices that individual patients will be faced with. And so let's just also circle through. I'm going to kind of throw out for the other panelists today. Any of the health equity issues that we are touching upon, the cost sharing, whether you want to go back to DTC, the stigma and bias, what are some of the things that you see as priorities? I'm going to start with the clinical experts on this. Alexa, if I could go to you here. From an equity perspective, the patients who are coming through your clinic, what do you see as the top priorities for us to address?
Yeah, I mean, I think access to a physician who can use these medicines.
Let's add that to
So-
the structural things that are happening. Can you get a primary care physician? Sorry, please keep
Yeah.
going, Alexa.
Yeah, and also, training the current physicians and the new
Yeah.
generation of physicians on, everything we talked about earlier today on obesity as a chronic disease. So I really see all these structural issues as one of the biggest barriers to
Okay.
trying to eliminate these inequities. And it is, yeah.
Thank you, Alexa. That's perfect. Melanie, what would you add from your perspective?
There has to be this balance because we really do want to increase access and certainly not have some of the experience that Joe's talking about. I mean, when my patients get on a medicine that is working really well and then they have to get off of it, like forget the potential health impacts of regain the weight. That's a very strong, distressing thing to have happen to you. That you have something that's working and then you take it away. It's almost worse as if never giving it at all. When we talk to our patients, and I've been doing some qualitative research around this. But I think when I look at what's happening with compounding, and you have this all of a sudden this huge amount of access where we don't have the wraparound services, it becomes a safety issue. And so I like posted on LinkedIn the other week because I went on to a site that was promoting the medications for cosmetic use. And I went on there and put in my current BMI, which is 22, which is not, and they said I could be 105 pounds, which I haven't been since I was 12, since, and I thought I'd speak to somebody and they just sent it to me. They just started saying you're compounded. So if we don't have the people to deliver it, then it's going to be other people delivering it who are not going to do it safely. So we don't want to do increase access without having some safety parameters in there. And also we don't want to increase access for wealthy people and not people who are more vulnerable. So it is complicated. I just realized that, but
Yeah, I mean, the
it's
complicated is
balancing
probably,
it. Yeah.
yeah, I mean, it's going to be a theme for how we unpack this. And I don't think that there's one solution here. So that's, I guess, the good news when we get to the policy solutions perspective. I think that it is going to take some creativity and some differences. We probably come back to compounding. I'm glad you brought it up just on the safety issue. I'll throw in also the direct to consumer for me is helpful in that those prices are coming down from 500, and that's what we're sort of hearing from last week. They're still largely unaffordable for a big swath of our population. And we cannot lose sight that even the starting dose at 150 and then eventually the 250 it can be cost prohibitive. I also think that we have to remember we have a complicated system where some people aren't even sure what a deductible is and might be surprised when they realize buying DTC does not apply to their deductible or their out-of-pocket max. So some other equity concerns I have there. And then to dovetail on what Melanie said, the safety issue, I've been making this, I don't mean it as a joke. Pat's not going to take it too personally. For however you feel about PBMs, they are the one organization that knows every medicine that you're on most of the time and can identify safety issues and deprescribing. And if we start having this piecemeal approach, I have some worries there too. And so we're probably going to address some of that when we write up some of the policy solutions that are existing with these machinations. But we don't want to lose sight of the impact that those have. Alexa, go.
I just want to tack on to the access issue. Is we cannot increase access without increasing support. Like these medicines are not effective if we do not have adequate follow-up. So I just want to really emphasize that. I see that every day in practice across all the patients in my clinic. And then I also just want to comment that we're having an interesting experiment that will be going on in Massachusetts starting next year, where Mass Health and our Medicaid is going to continue coverage of these GLP-1s, whereas many of our commercial insurers are not. And so, although that may be just temporary, it may improve some of the inequities that we're seeing in prescribing
Yep,
and
I know.
access.
There's some real world experiments sort of happening, but I appreciate the reminder that, and you all keep me honest through this conversation. We don't want to overly focus on the affordability. I mean, we're going to focus on the affordability, just the math of the cost of the medicines and the eligible patient population. The structural challenge of having enough of a support system to be able to safely prescribe these is another rate limiting step to getting to that full access. And so that has to be kind of put right next to. Pat, did I poke the bear?
No, I wanted to actually, I couldn't agree more about wraparound services and the need for
Great.
behavioral counseling and coaching in the journey of your weight loss. And we know that from smoking cessation from 30 years ago. And so this is no different than that, in my opinion, having run a practice in general internal medicine teaching clinic as a pharmacist to help people quit smoking. But I actually want to comment on what Dr. J said, because the example she used is compounding prescribing, but honestly, that's what's happening by certified physicians as well in legitimately trying to prescribe GLP-1s using the health benefit, and that's why we need a prior authorization here. So for as much as I don't want to, have a prior authorization, there is substantial misuse and bad behavior that exists for these products by, physicians with licenses. We have a good example of a dermatologist in 2021-22 was our leading GLP-1 prescriber. And when we went looking for details as to justification by to the label at that time, many patients were not meeting that criteria. So as a fiduciary on behalf of the health plans, it's through the PBM. It's not the PBM, by the way, that is putting forth, and we are running programs on behalf of self-insured employers and health plans to ensure appropriate use.
No, Pat, that theme's going to come through. And Tracy and Jason, I'm going to come to you in a second after I go to Joe. We have criteria that we put forth through a multi-stakeholder process of talking to patient groups and clinical experts, as well as manufacturers, payers, and PBMs. What are the criteria for prescription drug policies, coverage policies? How do we do this ethically and fairly? And just a preview for all of you, when we write up the policy recommendations today, we're going to pull through some of those themes. They might come up in the conversation, like when is non-medical switching allowed? When is prior auth allowed? And I think that there are opportunities here to understand sometimes we need the prior auth to ensure safety and appropriateness. And when you have something this popular, unfortunately, that can bring out some bad behavior. And so how are we managing that as a system so that we're making sure safety and appropriate use are there? Joe, go ahead, chime in on this, please.
Yeah, so maybe this surprises both you, Sarah, and definitely Pat, that actually we're not opposed to prior authorization. I'm going to steal some language that Michelle Tedder, who's on with us today and sits on OEC's board, used at an OEC board meeting when she said, what we want is prior authorization with wisdom, right? Prior authorization is actually based on let's making sure people get the right care instead of being punitive. And at times, I know not intentional, but at times it comes across punitive. So for example, if I was going to go through a prior authorization process, I've been in a dozen behavioral programs in my lifetime. I've been on 7 medicines now to treat my obesity, right? How does your prior authorization reflect that? Like, you can't make me jump through 5 medicines again to do this because I've done all those, right? And this is not new, right? Kind of thing. And so I think a lot of that is what we're talking about here. And again, I agree. I think we can build a system that makes sure that these medicines are used in appropriate populations, but also is fair and not overly burdensome.
We appreciate that, Joe. And those are consistent with some of the criteria that we have in our fair access paper about when please don't make someone try something that hasn't worked for them. The non-medical switching is if they've already not responded to the drug you're trying to switch them to, don't do it. And so there are some ways that we can all have a touch point for making it PA with wisdom, which I am also now going to steal from Michelle. Thank you. That's excellent. Tracy and Jason, going to you just a little bit about the way that you think about your responsibility from some of these health equity concerns, the access from a health equity patient perspective. Tracy, I'll start with you.
Sure. And Sarah, thanks again for the opportunity to join. We talk about health equity. I'm struck by a paper that was put out by Claire Yang at UNC a couple of years ago, where she looked at obesity over the life course and Black African-American women as we know generally, but across the entire life course, suffer the highest risk and realization of obesity level BMIs. I think the first thing that we have to do, connecting to the discussion on bias and stigma, is increase awareness and agency and receptivity to engage the health system. It really is the previous experience of stigmatization or the fear of stigmatization that keeps people out of the healthcare system generally and in meeting with a healthcare professional specifically. So I think that's really important. When they are there, we need to make sure that there is a patient-centric, evidence-based discussion happening. And there's a mutually agreed to plan put together based on their health status, their health aspiration, and their health needs. Necessarily, that means that we need access to all forms of care. And this is a really important policy position that we've had and that we maintain. We feel that in order to engage obesity across the population in the United States effectively, we need to improve use of all forms of obesity care. Behavioral therapies, all forms of medications that are FDA approved, and surgical interventions. And then having the appropriate wraparound care to aid in the success of the decision that was made collaboratively between the patient and the clinician. But bottom line, access is important. And Lilly, when we launched our medication initially, we launched it at a 20% reduction compared to the first agent on the market. We have been thoughtful, I think, between then and now on how we are engaging healthcare plans on pricing. And then I think the announcement that was made just recently is a bold and strong example between both of our organizations on improving access. We're open to collaboration, and we look forward to ongoing discussion on all these topics.
Good. Tracy, really appreciate you being here. Jason, give us the perspective of Novo and how you guys are thinking about the health equity piece of access.
Yeah, so I'm very much aligned with the comments that Tracy and the others just shared. I think from our point of view, we're very strong believers in the medical model of treating obesity, right? So things that I think others have mentioned, shared therapeutic decision-making, individual assessment of benefit risk, comprehensive holistic obesity care that includes ongoing monitoring. These are all themes that are very, very important for us. From the health equity lens, I would just add maybe a few other comments. Number
Please.
one is culturally appropriate and culturally sensitive care that also is provided within the context of someone's community and also addresses social determinants of health. We see that also as very important issues. Now, Sarah, you also mentioned DTC a little bit earlier, and maybe, maybe in the early days, some people thought that that was a way, to solve some of these problems. But I think from our lens, we recognize that we need multiple solutions to really address and expand access. And, in a very fragmented US healthcare system, there's not going to be one solution. And we recognize there are patients out there who even the DTC price is they're not able to reach. And state Medicaid programs may be, a more reasonable, option there.
Yep.
So anyway, that's kind of our perspective.
I appreciate that, Jason. If I could probe a little bit, I really appreciate that you brought up the culturally appropriate, the social determinants of health. Anything from programs that you guys have been participating in, conversations, things that you have seen working that you want to make sure we highlight to ensure culturally appropriate care?
We have relationships with different organizations and things like cities to improve, health, where we've kind of trying to take this up on the city and regional level.
Great.
So I think those are things that we're trying to do, really kind of on the local and community level. Those would be really the main ones.
That's great. Michelle and Joe, can I put you on the spot? Is there anything that you've seen working out in the community? And this culturally appropriate question, I think, is important for us to highlight in our policy recommendations. Michelle?
Yeah, definitely. Thank you for raising that issue, the culturally appropriate care, because in our work at the Black Women's Health Imperative, one of our signature programs is we have a high touch coaching model with our diabetes prevention and diabetes self management. But the piece of that that has gotten really a good bit of notoriety is the fact that we pride ourselves in meeting people where they are, making sure that there's representation. And many of the folks who participate in those programmatic things, one of the biggest things that they highlight is that they feel safe in an environment with people who look like them, who've been through the same thing as them, and who can honor their cultural nuances and the intersectionality of what that means in terms of managing chronic disease like obesity. So I think that it's really important for us in these rooms um, to know that representation matters, because somebody mentioned about, engaging with the healthcare system, right? But oftentimes when you engage in the healthcare system, there's not a lot of people who look like me.
Thank you. Yeah.
Okay. And so, and I can even say, even in my professional capacity, when I was working in the hospital and in clinic areas for many, many years, I was the only person who looked like me serving others.
I appreciate that point. We're going to make sure we weave that into some of the recommendations of the way the health system can improve. And I do know there's some work coming out of the NUDIX program at Tufts that's talking about the transformation that we need in our obesity care system. And I know that they touch on this, and we'll just make sure that we're highlighting that piece. I'm also reminded of a review we did years ago on community health workers and the wildly cost-effective role that they can play in our healthcare system. And one of the stories that we heard was that one of the patients with HIV, and forgive me, I think it was HIV, her viral load was not getting addressed by the medicines that were being prescribed. And it wasn't until the community health worker went to her home to realize that she had roommates and that she was trying to hide the medicine from her roommates. And it must have been something that needed to be refrigerated. And so she wouldn't put it in the shared refrigerator. And the community health worker bought her a dorm fridge, and that solved the problem. And so, anyway, that sticks with me. Is sometimes we, with our privilege, can forget that those are things that are happening to communities. And so I appreciate that this came up. Alexa, I'll have you chime in. And then, Joe, I'm going to go to you for any other reflections on this, and we'll move on.
Just another example of culturally competent care that I think we can work on is nutrition counseling, for example. So, everyone knows of the My Plate, which not everyone eats on a plate. And not everyone, the Mediterranean diet is, kind of a misnomer. And so I think training people in this field on culturally competent nutrition is really imperative as well.
We'll make sure we mention that. That's a great one. Sorry, Melanie, go ahead.
No, I just wanted to say that we've also used peer coaching for weight management in our veteran populations. I think there's a lot of lessons that can be taken from the lifestyle and the diabetes prevention program, and that can be then applied. We haven't done those studies yet, but I think a lot of that can be applied other chronic disease management things. And then the other thing I want to bring up with lifestyle, because lifestyle itself is really, really important, and yet recommending lifestyle can be stigmatizing depending on how you do it. And one of the reasons is because we do it mostly for obesity and we don't do it for the other chronic diseases. And so I, in terms of restructuring, would have a kind of universal precautions for lifestyle, or because I can't think of one chronic disease that does not improve with lifestyle, and that just be the baseline that we want all of our patients to get. We all can work on various aspects of our lifestyle with a community health worker or a group program or even AI and technological solutions, which might have to come into this. And a lot of companies are developing technological solutions to kind of facilitate weight management. And so I think all of those tools, but we don't want to stigmatize people with the lifestyle, even though it's such an important recommendation.
I really like that. We'll make sure that we reflect that as well. Joe, from your community's perspective, just this cultural competency, cultural appropriate care, what are you seeing?
Yeah, no, I think I was going to highlight Michelle's work at BWHI, but I think we see other groups adapting kind of the DPP model, which of course Everyone thinks of the diabetes prevention program, but in my opinion, it's really a weight management program. We got to convince the CDC to let us label it that way and open up the where I'm probably creating a big controversy by saying this, but opening up to a wider population again to provide some of that wraparound support moving this forward. And I really just want to emphasize what Dr. J just said a minute ago. If we're only counseling people about nutrition and physical activity when they live in a bigger body, you're actually part of the problem, right? You are engaging in the stigma here. Everyone should can be counseled about their nutrition and physical activity, and we need to stop. We need to stop that behavior, right? Because that's part of stigma and bias and a big part of it.
Thank you, Joe. We're going to move on. We're going to get wonky. I want to talk about some of the policy solutions that have been floating out there just because it's so top of mind, the big announcement from last week. And so given that this video gets posted and who knows when people are watching it, and things could change 5 minutes from now, we are talking about the announcement from Lilly and Novo that they will offer a much reduced price to the Medicare program for both Medicare, to CMS. So both Medicare and Medicaid could have access, talking about $149 for the lowest dose, up to $245 for the maintenance dose eventually. There's going to be a DTC option at that price. This is just a pretty big moment in how we're thinking about access in Medicare. For those that don't know, Medicare has been prohibited from prescribing these drugs for obesity because of longstanding bias that was put into law a bunch of years ago that many have been trying to change, and Joe and his group have been leading the way. But this moment represents an interesting reflection on the role of federal government in providing affordable access, the role of price choice and price reductions. So we want to kind of touch on that. And then we're going to flow into some of the other policy options that have been floated around, talked about today. We've talked about carve-out programs and support programs a little bit. I think we talked about Connecticut and AT&T earlier, so I want to touch on that. I want to think about some of the innovative payment models. Tracy and I had the opportunity to be on a panel together yesterday, and we talked about subscription models and what other options for sort of budget certainty. And I'm going to go to Alyssa on Pat on some of those. And then the sort of rumors of a CMMI model. If anyone wants to talk about rumors, we can do that today too. And so I just wanted to make sure that given how different this policy roundtable is, I mean, we've got white papers on the policy solutions, we've got breaking news every week. Let's center what we think can work. And Tracy and Jason, I'm going to start with you guys. Share what you would like this audience to understand about the motivation for this announcement last week, what this represents for your commitment to getting broader access. Jason, let's start with you this time.
Yeah, so I think this is a really important first step. And, our position is anything that can expand access and really allow patients to have access to these important medicines is very important. And that includes whether we're talking Medicare or whether we're talking people who are in Medicaid programs, or even those who may not have insurance or have some insurance but don't have coverage. So for us, this is a very important step to really open up and improve access. And we see it as kind of the first step, and that more work still needs to be done in the future. Obviously, it's very fresh and new and still evolving, and we have to learn some of the practical details and how it will be kind of rolled out. But that's kind of our thoughts.
Thank you. Tracy?
Yeah, certainly in agreement with Jason's comments. And to add, I think this is representative of our industry continuing to find a balance between the remarkable investments that we make in order to research, develop, test, and bring to the health system innovative medications, and playing our part in improving access broadly and durably to these medications. The United States has a significant health and economic issue as it relates to chronic diseases broadly. We all know the percentages. And obesity is a disease that has not been treated appropriately. I think our decision is a contribution to advancing access to all forms of care so that we can engage this disease in a way that is meaningful. We can improve health. We can improve quality of life. We can improve the economy of the United States. Our leadership really looks at this as a public health opportunity. It's something that we're proud of, and we will continue to keep our shoulder fully in as we're working with Medicare, all states from a Medicaid perspective, and of course, continuing to work directly with the commercial environment and via our direct-to-consumer.
I love the energy that it's a first step. Thank you. I think that was Jason who said that. I'm going to ask a question that I fully expect Tracy and Jason aren't going to answer, and that's okay. But I'm going to put it out there. So does that mean the prices could come down even more if this is a first step? Answer
Well,
if
you know,
want.
sir, in a public forum like this, we can't discuss things like that, obviously. So, yeah, I mean, you understand
there
we
you
can't
go.
discuss those things in a public forum.
Yeah, and
Jason?
Sarah, I would just add, I think we know, when there's competition in the marketplace, we see the trajectory of prices over time. That's a very, important concept. And obviously this space, although maybe there were challenges historically with, issues with anti-obesity medications, but we're seeing how much development and drug development is going on now. And there'll be much more, competition coming in the future too.
Yeah, the pipeline is pretty robust. I appreciate you both being good sports about that. Thank you. Joe, go ahead.
Yeah, antitrust gets in the way of those kinds of discussions.
Well,
Little things.
Pat's here. Sometimes it's good. Pat's here, Alyssa's here. No, I understand. I completely understand. Joe.
So Sarah, I'm not bound by those restrictions. So I will
Great.
say, as somebody who's punched on both sides of this equation, right, where we've been punching at our friends in the drug industry to lower these prices and punching at our friends in government to, basically create access to this. I'm pretty excited about where we are. And as mentioned before, there are literally 100 agents in development. And there are people that we're engaging with already who are developing agents that they expect to be much less expensive than the ones we're talking about now. Not the level of prices we were talking about before to meet your 800 million model or whatever that was, but there are going to be medicines that are priced even less than this coming in the near future. So I think we're in this weird point of early adoption of obesity medicines, but also probably at the most expensive they'll ever be, and the price is going to come down pretty rapidly in the future.
I really hope you're right, Joe. And I do, and I will happily add, to not put anyone else on the spot, to do so. We also know that semaglutide is going to go generic in 2030, 2031. We don't know exactly when. And so there's a cynical take here that I sometimes carry with me, which is we're probably gonna screw up broad access for a couple of more years until we either have more competition or we have the generic. Just where we are with the number of eligible patients and the stress that we already have on the affordability of our healthcare system. So I promised to bring a lot more optimism today. So I'm going to try and only have that one Debbie Downer moment. But Pat, bring us back to reality, or how we're thinking about this.
I think I might add a little more downer to the state. I mean, asked earlier today was like, what's the cost right now? Like, what are we running on an expenditure basis for all of our drugs that we pay for with our pharmacy budget? So in entirety of all drugs processed through the pharmacy benefit, right now, in Prime's 6+ million health insurance marketplace ACA lives that don't have coverage, to another point made by Michelle, vast majority of lives in ACA do not have coverage. 10% of all drug spend is for GLP-1s for diabetes. We forget about how much and how great these drugs are, but at the price point of roughly $1,000 a month. Now, ICER in their report identified, a price point of 7,000 annually, at $1,000 per month. That's 12,000. So, there's discounts in the marketplace we already know about, but still, GLP-1s for diabetes alone represent, at the price point of $1,000 per month, 10% of the entire budget. For self-insured employers that have opted into coverage, then you add potentially another 10 to 20% that we are seeing right now as of August. So that's the month of August of 2025. So it is not like out of the realm of what is reality to have 1/4 of your budget in GLP-1 expenditures if you have weight loss coverage with diabetes coverage. That's not affordable. And another point is that for every 1% of utilization of the population, so if we know it's 40% that are meet the criteria of obese. For every 1% of the population that uses a GLP-1 at $1,000 a month, you bring 3% new expenditure.
Right.
And
if I could, no, please finish, Pat, please.
Well, if it's 350, then you're bringing 1% of new expenditure for every 1%. So if you add 10% at a price point of 350, which is wonderful. That's 1/4 of the price of the list price. Very optimistic we can get there, in the future. But even so, that still is not going to be affordable for many self-insured employers to make a decision for coverage.
And I think that what you're touching on, and you've articulated the tension very well. We've talked about it throughout the day. We so fundamentally at ICER believe in this idea of opportunity cost, that when we spend a dollar for something and we choose to spend it for that, we don't have that dollar to spend on other priorities. And that's the energy we need to bring to the policy solutions, because we can't pretend this is the only priority that we have in the healthcare system. And it's a fixed budget for a lot of employers. And if we think, and the head of Blue Cross Blue Shield in Massachusetts said this yesterday at the cost trends hearing, it's especially facing our current environment where we're going to have less money from the federal government for healthcare. That's what's coming with the changes in Medicaid, the ACA. We can no longer expect consumers and employers to pick up that gap. So that on top of this, which even at the lower prices, which yes, let's celebrate that we're getting the prices down, we still have such a large eligible patient population. Alyssa, you've been very patient. I know that you talk to a lot of payers. What would you like to add to the understanding of this sort of trade-off that they're facing? Effective drugs, cost-effective, big patient population. How are they thinking about the price and access question?
Yeah, absolutely. So, Sarah, you summarized it great. At these current costs, it's just not sustainable. So payers are trying to look towards different solutions to offer coverage, even if that is just to like a subset of patients under this massive umbrella, at least until we get to a point where hopefully we do in the future where prices are driven down enough to make broad coverage possible. So in the interim, we see payers exploring so many different opportunities. Through prior authorization. And Joe, your point was very well taken that some of these criteria we're seeing that are more or less just barriers to get over, like these lifestyle programs. But I'm talking prior authorization criteria that limit the population to at least be able, that payer, to enable that payer to be able to offer coverage to a subset of this population in a reasonable fashion. So I'm talking like higher BMI minimums than the label. Holding people to higher benchmarks of weight loss for continued approval, more than 5%, or different kinds of innovative contracting models, as you alluded to as well. But the majority of these are met with resistance from the manufacturers for the potential loss of rebates. And payers really feel like their hands are tied, that they're not affordable at scale, even at their rebated price. And so the threat of loss of rebates is a huge deterrent for a lot of payers. So I think what we really need to accomplish, at least to get past this interim period where hopefully costs continue to come down, is a better partnership with the manufacturers and the payer to be able to work together towards a solution that provides coverage to at least a subset of this population until we have those lower costs, which I believe is the only true solution here at scale.
Alyssa, you touched on something that we had in our policy paper that came out in April, and it's not our favorite thing. And we had the pleasure of Pat and Joe being part of those conversations, sort of limiting the eligible patient population either by BMI or comorbidity as a way to at least have some access that can meet your budget targets without raising premiums and cost shifting and all of those things. And so I think that's an important one to acknowledge is still on the table, even though we all know that feels crappy. Like we know the drugs work for, the BMIs that were studied, but we're, again, trying to deal with this tension of affordability. I also wanted to comment, have also heard sort of where the rebates land based on what kind of clinical criteria might be in the coverage policy. And again, I am not going to make Jason and Tracy answer this if they don't want to. But one thing that I have noticed about now a very public net price being offered to the federal government is maybe there's a shift in that dynamic in terms of like what kind of discount can I get, and I still want to be able to maybe limit the population in order to manage my budget. So we can watch to see how that changes some of those negotiations and those dynamics, because until last week we had estimates of that net price. We didn't have these public commitments from the manufacturers. Melanie, please come in on this.
Yeah, this is more of a question because it's not my area of expertise, but when we're talking about the overall prices, like for instance, of diabetes being 10%, how, like if people are on insulin and you can get off insulin and you can have more aggressive ways to get off insulin and other medications, like how much of that can be offset? Because when we're making some of these decisions.
Pat is shaking his head. I'm not sure everyone in the audience can see that. So he's not seeing a lot of offsets in that spend. Is that what you wanted to share, Pat?
Yeah, it's not happening. I mean, the
Okay.
price point for insulin is substantially lower than a GLP-1 to start off with that in diabetes. But if you want to look at just obesity, we've done a 2-year real world study of following individuals matched up. I'm going into, you can Google it on Prime Therapeutics website and GLP-1. There's no cost offsets in the first year in the real world. There's none. We're not seeing less statin use. We're not seeing less RASA use. We're not seeing joint replacement lower. We're not seeing bariatric surgery. There's no cost offsets occurring in the first 2 years of following people in the real world and commercially insured in the treatment of obesity without diabetes compared to net controls.
And Pat, and we've had this conversation, and you've heard this, and you mentioned earlier as well that sometimes the healthcare costs are going up for patients who are getting treated for obesity. Let's not act like that's necessarily a bad thing.
Correct.
So and I know you don't believe that too, but just for the audience and for when someone has had a condition that's been stigmatized by the healthcare system, they have not come to the healthcare system for a whole bunch of other things. And so it is good for overall health. It doesn't help the budget math. And so both of those things can be true at the same time. So I just wanted to add on to that
it's an
point.
investment, and it should be. And
Right.
that's the
And it should
problem
be.
we have right now with self-insured employers believing that they're going to get offsets in the first year or 2, 3. Yeah, it's the same thing treating hypertension and hyperlipidemia and many chronic conditions. It's an investment for the future, but that's not what a lot of individuals in human resources and self-insured employers, think it to be. They expect savings in year 1 and 2.
And they're thinking of things in 1 or 2 or maybe 5-year budget cycles, which don't often give us the opportunity to see that return. That's a big ask from an innovation to give you an ROI in 2, 3, or 5 years. Over a lifetime, our model is showing absolutely cost-effective tirzepatides approaching cost saving with some of the net prices we're talking about. But again, that's a lifetime. And so when you're making those decisions for your plan, that it's, again, you've got to tell your CFO something, and it's usually in a 1, 2, or maybe a 5-year time horizon. And so again, the math isn't mathin', but we're starting to circle around some ideas and some opportunities here. Joe, please chime in.
Yeah, so I first of all, I think in terms of the study that Pat mentioned, I think I agree with everything you said, Sarah. Many of us who have avoided the healthcare system for a long time, and then therefore we get caught up in that first year or that first 18 months, and then so maybe that timeline needs to be a little bit longer, but the data will have to show that. We'll have to wait and see what that data looks like. I was actually, my hand went up originally just to talk about, when you were talking about clues to what what some narrowing of population might be. And I think there are going to be clues that are going to come out of this Medicare project that is, the Trump administration proposed and the Trump administration announced along with the CEOs of Novo and Lilly. And that is looking, I mean, they're using a demonstration project. They're going to use a 402 demonstration project for the first year. So basically, they're going to go at risk and pay for every plan that opts into it to pay for folks' medicine during this time. But it is, BMI 27 with prediabetes, or BMI 30 with these other comorbidities, or BMI 35 with no comorbidities, right? So there was some population narrowing taking place there, and honestly, that probably captures most of the people who are having health consequences related to their obesity, right? So it'll be interesting to see. I mean, time will tell, and we'll be able to see the data in that natural experiment, or actually study, because it is the demonstration project that's going to happen. But I think it sends a clue, right, about how we can look at populations, and maybe, without putting Tracy and Jason on the spot, how their companies are thinking about populations being narrowed as well. So. Yeah.
Joe, I really appreciate that. I want us to we'll write that into some of our recommendations, because I think we might be at a bit of a sea change from what we were hearing now, gosh, 18 months ago when we were doing our interviews for our policy paper, and how much the landscape has changed about this question of narrowing. And I feel also a conversation Joe and I have had previously, and we'll get to research questions and research needs in a moment. We know that not everyone with overweight or obesity will have negative consequences from that. We just don't know how to tell the difference between those patients now. And so as we start some of these natural experiments of limiting to certain comorbidities and certain BMIs, will we start to learn more about the ideal patient, et cetera. So that's something that we'll put in our future research needs. Tracy, thank you for your patience, please.
Thanks, Sarah. I was just going to add a few thoughts on this really important discussion on savings associated with obesity care. It's necessarily a topic. And I think of this as, what is the trend in the data? And I think the trend in the data is that there is an increasingly supportive bank of data that there will be savings associated with obesity care. And we just this week put out the first literature review of all previous rigorously developed white papers and peer-reviewed work. And we looked at all forms of obesity care, because again, that's our fundamental policy position. We want to see improved use of all forms of care. And in looking at 31 rigorously developed white papers and peer-reviewed work, and finding a way to normalize the findings to $2025, there are, in fact, a reduction in expenditures from all previous literature. As we look at modern obesity medications in the commercial environment, with a relationship for every 1% reduction in weight, a correlative range in potential savings, anywhere from $1,500 to $2,300, even for intensive life management, a range between $400 and $600. So that's 30 plus previous studies. When we look at real world evidence, I think Aon was mentioned earlier, in 2 years, they saw a significant reduction in cardiovascular issues and a 7% comparative improvement in cost escalation for individuals being treated for obesity versus those who had obesity and were not being treated. I think finally, I would point to some of the thought-leading work coming out of USC as it relates not only to medical savings, but also economic capability of individuals, and then social benefits as well. They were noting as much as a 13% positive return when we look at the care overall. Now, I appreciate those who are managing P&L from a business perspective may not be looking that far out. But coming back to my initial comments, the data trend is positive right now, that there will and are savings or reduced costs associated with effective obesity care.
Tracy, I haven't looked at the Aon study in forever, and so forgive me. I did think that trend was excluding the cost of the medicines, and so I did want to make sure, because
that's
it's
right.
not that they were okay, because that's not
that's right.
showing. Yeah, so with the cost of the medicines, trends was going up. But okay, good.
Actually,
just wanted to make
and the
sure.
medical costs were not lower than the control group. So, I mean, and also I'll
Okay.
just add, that's only amongst adherent individuals. Only
Right.
study to be not in all comers. And then the third piece on your cardiovascular event reduction is a 0.04%, or number needed to treat of over 400. So although statistically significant, mathematically a difficult number to swallow from a, value standpoint.
When you're thinking about the budget. Okay, Pat, thank you for that additional context. Jason, please.
Yes, I just wanted to share a comment about the discussion a little earlier about narrowing the population. And I want to make sure that we just don't forget, something that's obviously very important and which this group I know is keenly aware of. Obviously, treating obesity is not just about reducing body weight alone and really about improving health. And I know there's been, discussions about, can we narrow the population by BMI or BMI class? And it's very important that we keep that in mind. And we also continue to look at the evidence that continues to emerge on weight loss independent effects, and that we really think about this issue in a very kind of a new way. Yeah.
No, I think that's a really important point. And I almost see a corollary, and the clinical experts are going to keep me honest on this. The same way that living in a larger body does not necessarily mean that you're going to have downstream negative health effects from that. It's the same. It's almost like the corollary of that and these drugs are doing other things besides just helping you lose weight that we don't all fully understand yet. So it's interesting that those two things are kind of going hand in hand as we continue to build a better understanding of this very complicated chronic condition. Melanie and Alexa, anything you wanted to keep me honest on there? It's dangerous when the non-clinician tries to draw those types of conclusions. Okay.
I think you said it right.
Sounds good. Yeah, you're going to have people who don't have obesity by BMI, who still have a large waist circumference, who still have cardiovascular risk, who still have, the whole Lancet commission trying to redefine preclinical clinical obesity, looking at measures of adiposity and there's a whole, whatever we want a policy of how we even measure and define risk could change who's eligible and all of that. So that's even a broader conversation that we didn't really touch on.
No, and I had it on my list of things for potential future research needs, and so we're gonna add that to our section, because whether it's the waist hip circumference is a better measure, the adiposity, appreciated. It came up earlier today, just understanding that yes, you might have what's considered a healthy BMI, but depending on where you might be carrying extra weight, that actually does increase your risk more than somebody who might have a higher BMI and have their weight distribution be in different places. I'm reminded of a review that we did a couple of years ago on spinal muscular atrophy. Come with me on this tangent. I know it seems random, but when we were talking about Zolgensma, which was one of the first gene therapies approved, we were talking about all these other benefits and all these things, great drugs, saving kids' lives, right? These kids often didn't live past 2. And the neurologist that we had on the panel, and she said, one of the other benefits is I was going to retire, and now I don't want to, because I finally have something to offer my patient population. And I see a corollary to, we are breaking down the stigma. We are breaking down the bias. We're starting to ask research questions that many members of the community, including Joe and his team, have been wanting the medical community to answer about this. How do we do something better than BMI to really understand risk? How are we prioritizing the patients who would have the most benefit from GLP-1s while still prioritizing access to all of the other interventions? And so to me, there's something we can celebrate, that having these two very effective, very cost-effective medicines is actually elevating the understanding of this condition in the same way that having a cure for SMA made some neurologists not want to retire because they were so excited to keep practicing. We've got about 20 minutes left. I do want to spend a few minutes on future research needs, but I also want to go to Alyssa and Pat a little bit in the weeds on payer coverage policy. So we've touched on this a little bit. What are we looking for to make sure that we're giving fair access? We can think about the ICER criteria for that. There's a few things we've heard in our conversations with patients, and Joe and Michelle can chime in and keep me honest here. One that we've heard that we would like to make sure payers are thinking about, and you can tell me if this is a challenge, patients are sometimes challenged for continued coverage because they've lost enough weight to no longer meet the criteria for having a high enough BMI to get the drug. And I just want to, Alyssa and Pat, is there anything that you've come across on how you're doing coverage policies or how payers are thinking about this? This seems like one we should be able to handle through coverage policy. Does that seem reasonable to expect through a good coverage policy that yes, I can keep taking it even though I'm no longer at a qualifying BMI? I'm looking at positive body language from both. Okay,
Oh,
great.
absolutely. And I hope that that is not occurring frequently. What we typically see most policies, instead, they approach that as a maintenance of the original weight loss. So that might look different for first approval after whatever that initial approval duration is, and then subsequent approvals after that typically switch to that maintenance framework. And it is my hope that that is more common, because obviously we have a great understanding that, if you withdraw the drug, you oftentimes return to the original BMI. So it would just be a cycle. Yeah.
Right. And we're trying. Okay, great. That's excellent. Joe, please come in on that.
Yeah, I would just say that I think sometimes that's disguised a little bit less directly than you're saying there, which, for example, a lot of times now employers are hiring specific telemedicine providers that they carve out their obesity care. They make them go to a certain provider. Now, don't get me wrong, there are some amazing ones out there doing that, but there are also some that actually market their businesses that they're going to de-prescribe GLP-1s, right? And so I've listened to plenty of phone call with one of those groups where at the end of the call, I hear them selling to the patient, well, when are we going to start taking you off this GLP-1? And these are not people who have BMIs of below 22, right? These are people that still are in the overweight, or even many times in the obesity category. And so that's a challenge, right? And we're looking at a short term, hey, I can prove my firm's saving the company money versus what's long term and best benefit for the patient. I see I sparked Alyssa, so go ahead, Alyssa.
Yeah, please, Alyssa.
Yeah, no, absolutely. And that's a question we get, weekly is, how can we and how can we get patients off of these medications so that we don't continue to have this impact to our budget. And I think that's a huge, area of future research need is there a way to do it effectively, safely, that's in the patient's best interest? And if there is, how can we help facilitate that as a payer?
Great. That's added to our list of future research needs. Michelle, please.
Yeah, but I also think that we need to have the conversation around the power of bias in the infrastructure of the system around this, because if you are, have high blood pressure, people are not pressuring you to get off of your high blood pressure medication. And I think that there's still this pink elephant, if you will, in the room about whether or not we do indeed have a consensus that this is a chronic disease that requires chronic intervention. Because if that was really the core belief, we wouldn't have so much variety in how people are thinking about it, and even providers saying things like, well, when can we get you off of this? How can we? Because there's still this underlying belief that still there might be some way, somehow, that the patient and something else can fix this problem, when it's really a metabolic issue that most people, when they've gotten off, we already know the answer. We already know, because before you got on it, you were sick or on your way to being sick in so many different ways. So I think that we still have to keep coming back to the structural bias that exists amongst the system, whether you're a healthcare provider and even patients feeling that way, whether they're willing to admit that or not. But it's like, well, can I get off of this? What do I have to take for the rest of my life? And those are not the questions that people are asking when they have some other chronic disease that is acceptable, so to speak, to be on lifelong treatment for it.
Michelle, and I want to double click on that point, because the extent for which the bias has infiltrated all this is the fact that so many patients are asking, when can I go off? Because they've internalized that they don't need it forever. They just need this kickstart. That's what I've heard from talking to patients, and I'm sure you and Joe have been hearing similar things. And so, again, I am celebrating the progress that we have made, even in the 3 years since we did our last obesity report, while still highlighting the continued work we need to do there. Pat, to you.
Well, I want to somewhat agree with Michelle here, but there is uncertainty. There's uncertainty of the need for life. There's just, we don't know. that you need lifelong therapy. I mean, there will be people that need lifelong therapy. I'm not going to disagree with that, but is it everyone? And is it even the majority? Because you didn't get to that weight without, we didn't have this problem 20, 30 years ago in America. So this is a change in the American lifestyle that has resulted in the proportion of people that are obese. I mean, that's a fact. So that if people do make the change and in the way they exercise and eat and lose weight, do they really need to, for all of them, all 100%, need to continue for life? I don't know the answer to that question, and I don't know that we know until we have done more research on this.
Well, I'm definitely including it as a research question because I do think there are questions we can answer about ideal patients that are going to respond, patients who might not need to be on it forever. But I also want to make sure that our continued understanding of this, and yes, there's been an increase, does have a lot to do with the built environment. It has to do with access to healthy foods and healthy neighborhoods, institutionalized racism. It's complicated. And I just, so everyone who might only be seeing me right now listening, there's a lot of nodding heads across everybody here that we're all on the same page with that. It doesn't mean we can't ask questions about how we're going to design a research agenda to make sure we're understanding this. But we also want to make sure that we are not, given the data that we have right now, and I think Pat would probably agree with this, we don't know who needs to be on it forever or who might be able to come off. And that makes it really hard for Melanie and Alexa when they've got patients in front of them who might be coming with their own ideas about how to handle this. And so that point is really well taken. We'll make sure it's addressed on the research needs. That spurred lots of hands, which I'm very excited. I'm going to go in the order I have on my screen. I'm also going to give everyone their 15-minute warning that as we wrap up in a couple of minutes, everyone gets the opportunity to ask someone in the ecosystem to do something differently. Like, what if you had a magic wand and you could get someone to do something differently, what would it be? And that's how I want to make sure we end today. I'm going to invite optimism and policy solutions, not just we need to do better, which I think is the theme that we can all agree to, but start thinking of your magic wand moment. Jason, you've been waiting patiently. Thank you. Please chime in.
Yes, I just wanted to echo Michelle's earlier comments because I completely agree with her. You know, the bias and stigma, obviously not just against people with obesity, but also even against medications for obesity. And one or two comments I wanted to share is, you know, when you think of, and Sarah, I think you brought up the example of people, you know, coming down with their BMIs and then medication being stopped. One very important word when you look at the labels for these medication is initial and initial BMI. And that's a very important thing to remember. And then I'll just also share a little bit of a clinical lens that the calculus changes when you have a cardiovascular benefit and a death benefit and stopping medications. So it's something just to also keep in mind when you have proven benefits there.
And just to that point, I think part of the research agenda is for us to continue to understand what it is about these medicines that's conferring that, right? Just that we want further understanding about how they're addressing those important outcomes. Melanie, thank you for waiting.
And can I talk about research, other research?
Yes, of course.
Well, so first of all, I think that to my point about coming off of other medications, there are interventions that people can do to go against clinician inertia about keeping people on medications. So we have a pilot, not me, but like a colleague of mine at Bellevue Hospital is doing this nurse texting program with patients on insulin to move them over to a GLP-1 and get them off the insulin. We could maybe do that with other things and experiment with ways that it could, because when my patients say to me, well, I'm going to be on medication, do I have to be on this medication forever? I said, I don't know, you might, but maybe we can get you off of other medicines. And so that's a research thing that could happen. I think that we have to know, I agree with knowing more about if patients want to get off, what's the best way to do it. And part of that is that there's so much experimentation going on right now that we're not capturing. So with all the compounding, with all, like my patients know more about these things they're like, oh, well, we just tried going for 10 days on the medicine. We just tried, taking, every 10 days instead of every day. Or we tried them, all the companies now are doing micro dosing, whatever that means. And in mainstream, when we're doing it by the book, we don't even know what works. Is there a way to capture any of this data? And Haynes is being decommissioned, but have some sort of population data, maybe all of us, maybe some other way to capture what's happening, to get hints of what might work. And that's a good thing. That happens anyway when new medicines come out. It just doesn't usually happen so fast. Like clinicians usually have time to figure out how to use the medications, what are the best patients. We go a little more slowly, like with statins, and then the price comes down and everyone gets on it. But here it happens so quickly because there's such high demand. The other lists that I would say is what order should medications go in, bariatric surgery versus medications first, medications versus bariatric surgery. What are the other indications that it can help with, that they are already being tested in addiction, Alzheimer's, and maybe for mental health? What, genetics and personalized medicine need to be looked at. And then how to best support patients, how to best support medication adherence in the long term. I think all these things. Yeah,
that's great. Melanie, those are excellent additions to the list. Your comments also make me think of, I bet that Alexa and Melanie do not have a lot of patients who show up asking to go on a statin, but do have patients showing up asking to go on a GLP-1. And we can't lose sight of the popularity of this, like kind of intersecting with that. There's probably like a TikTok video that's telling people to microdose or whatever it is. I mean, that's just a new reality.
There's such a demand. People are desperate. And some people, I just say, can be a little patient, like give it 2 years. But if you have a condition that's really hurting your life, you don't want to be patient,
No. Yeah, we're tend to not be a very patient society. I think that's fair to just put out there. But the other point you made that we talked about when we developed our white paper as well is this notion of deprescribing is worth exploring, because we have seen deprescribing in diabetes. There are some telehealth and some other virtual health companies that have data for that. And so I don't want to take it completely off the table as something. We just want to make sure we study it thoughtfully so that we're not doing it just for economic reasons, or we're not doing it just as a reaction to stigma and bias or whatever it might be. Okay.
Joe and Michelle. Life to be prescribed. Yeah.
Yes. Right. Yes. Joe and Michelle, you've been so patient. Please, Joe.
Yeah. Yeah. So Sarah, I was going to say something just like you said there at the end. I think, I'm actually part of a clinical, we're doing clinical guidelines around obesity medicines. And we look at the data, the only A-level data, the only high quality level data we have says that people should stay on these medicines long-term, right? We actually have no high level data about people deprescribing. Now, doesn't mean that data shouldn't be developed, right? But there are people out there selling that right now. And before you sell it, you first need to publish your data, right? So we can actually make that decision. Like, look, I'm the person who's been on 7 medicines in my lifetime. I don't expect to stay on the medicine I'm on right now for the rest of my life. I suspect I'll be in some form of treatment, whether that's medicine or maybe something cooler in the future, right? Kind of thing. But the reality is it may not be this medicine, but we have to publish that data, right? And I think that's the key to this moving forward. Before we start selling it and doing experiments on people without first letting them be informed consent about participating in those experiments, because that's what's happening right now. There's a lot of, and the same thing's happening with compounding and all the stuff Dr. J talked about, right? There's a lot of experiments happening in the world that actually are, people are, being included in these experiments without realizing they're being experimented on. So.
Yep. Thank you, Joe. Michelle, thank you for your patience, please.
Yeah, no problem. Yeah, I think that what we have to make sure that we're centering any research around is really the lived experience, because while yes, we can say, well, maybe, and most people who are on medications, I think, because there's certain medications that I have been able to get off of because my obesity was treated, and I'm thrilled about that. I used to be on statins and I'm not anymore, so that's great. However, when I think about centering it around the lived experience of the people that we're talking about who are living with this, is that many of us have lived with it our entire lives. And we have done the lifestyle change, the dance, we've done it. And so now these treatments are available. We finally have a tool, and it's all it is a tool. We finally have a tool that either enhances what we were already doing, which is the lifestyle change and the nutrition, because I still think there's an assumption that because you struggle with this, you must not be doing those things. And honestly, for those lifers, I'm like myself who've been dealing with this, trust me, we've done every last diet that has come out from 1970 until 2025. I promise you. But there's still, again, and I'm going to double down on this piece of stigma and bias that still exists that says, well, just maybe if we just take people off of it, when we do have evidence that when people come off of it, they start to gain the weight back, regardless of what they're doing in terms of these interventions. And so I guess my argument is, if we're not doubling down on comprehensive tool access, right? It's not either or, but it's comprehensive tool access, then we're going to miss the mark. And that needs to be centered around the lived experience of people who are living with the disease.
That's so well said, Michelle. And what I wanted to, and we haven't had a chance to talk about it too much, and I'll get to you in 1 second, Alexa. We mentioned it a little bit earlier in the day about some of the carve out programs and some of the support programs that are existing to help patients get the most appropriate care. So I think the ones that we have data on, or at least early data, are working the best are not a let me get you on a GLP-1 as soon as possible. It's let's understand what we know about your obesity, your health risk. Let's potentially talk about surgery. Let's talk about some of the older medicines. What kind of coaching and support can I give you for making sure if you live in a food desert that you're getting vegetables delivered, whatever it might be that's offering this comprehensive approach. And so after we hear from Alexa, if anyone has thoughts on how we want to structure a policy recommendation around this idea of some of these carve-out programs, some of these wraparounds, we know State of Connecticut has been doing work, AT&T has been doing some work. Those are ones we mentioned today, but I don't want to miss the opportunity to talk about that as being part of the solution here. Alexa, please.
Yeah, the one thing I wanted to add as an area of future research or ongoing research is just healthcare delivery and how can we,
Good.
try out novel methods of delivering GLP-1 care. So in our practice, I'm experimenting with how can we asynchronously titrate GLP-1s in a safe way. We can't have an appointment for every single titration, but a MyChart message is really insufficient in most cases. And then I know I'm biased here as a primary care physician, but the answer to your question that you just stated is I really think we need to amplify our resources in primary care because this is a whole person, a whole health problem. This is not a specialist problem, and really increasing access to primary care physicians and empowering them and the communities that the patients live in to provide the primary care, I think will go a long way.
Alexa, every conversation that I've been in the last 6 to 12 months about our healthcare affordability crisis ends up with please hire and more PCPs and pay them more. And so I am happy to add that to the list of things because it has more of an impact than just on this particular issue to try to address where we are kind of over this cliff. Joe, go right ahead.
Yeah, so I was thinking about one of the programs that you were talking about. That's the AT&T program that we've seen some presentations about. I think both of us have, and a number of us on this call, and a super impressive program. But I think what stands out to me, so I get a little nervous about these carve-out programs, again, for the reasons I shared earlier, that I'd be forced into one if I wanted to. But then I look at what AT&T designed, and it's actually very different than that, right? So their telemedicine provider has a relationship with the PCP of the patient that they're seeing with. There is a back and forth, right? So this is not you just carving out my weight loss. This is they're working with that specialist to then work with the primary care provider to be able to deliver that kind of care. And I think those are the kind of unique models that I think we need to think about. Because I'll be honest with you, I know we're going to have to use telemedicine, right? We're not going to be able to care for 100 million people, right? Without having all the formats. We're going to have telemedicine. We have to have primary care. We have to have specialty care. We have to have academia. We're going to have to, you name it. We're going to have it to be able to address this issue. But we have to remember this is more than just about weight loss, right? This is about health, right? And somebody has to be adjusting all these other medicines that, you know, many of us who live with obesity take. And that's what really scares me about the kind of the world we're in now with the carve outs plus the compounders, right? Who are not just sending people
Yep.
home and then not actually, you know, taking somebody like Michelle mentioned coming off her statin, right? Like there's nobody, you know, and those programs, that provider is not doing that for you. In fact, they're not even looking, most likely not even looking at your lipid levels unless you're in a high quality program like the one that we, you know, hear from Connecticut, which is Flight, and from AT&T, which I think is Forum, who runs their program. So
Yeah. Yeah, and I just think those are important caveats to sort of trying to, we're not going to center or carve outs as the solution for everything. There are some concerns, but I do think that there are opportunities to leverage some of those programs in order to, again, if you're a purchaser wanting to do this, they offer a cost-efficient way to do that in a lot of cases, and that's important progress. We are at the point where each of you get to wave your magic wand and ask for something from the system. It can be somebody or a perspective on this call, outside of this call, but we really want to hear from all of you and your expertise on what you would like to see changed. Tracy, I'm going to start with you.
Sarah, thank you. And thanks for this discussion. Thanks to everybody for their incredible input. You know, my comments can be pretty simple. It is, let's be collaborative in our work. Let's treat people immediately and with respect. And let's also look at and support the long-term approach of effective care for this disease.
Thank you, Tracy. Jason.
Thank you, Sarah. Pleasure really being a part of this today and a great discussion. If I had to wave a magic wand, I would say that I would want more people in society to fully embrace and act like obesity is indeed a chronic disease that needs ongoing and continuous care. And part of that, I think, is really understanding what Michelle talked about and going through that dance, you know, of lifestyle intervention in the past and what we have learned about things like metabolic adaptation and how challenging it is to sustainable and durable weight loss with lifestyle intervention alone.
Thank you, Jason. Alyssa.
Well, to avoid the obvious, which would be to call on the manufacturers to continue to make efforts in lowering price, until we have that broadly, I think I would call on our manufacturers to be more open-minded to opportunities with payers who are trying to offer coverage, at least to some patients in the interim. Be more open-minded to those kinds of criteria without rebate implications so we can continue moving forward in providing more patients with needed coverage.
Thank you, Alyssa. Pat.
Yeah, I mean, I'll just second that. I mean, these are amazing drugs. I mean, they work. I thoroughly enjoyed the conversation today and you know, Sarah and the modeling that was done. I will call out that the clinical trials average BMI was over 35. The model that you built was predicated on a 38 BMI. So I'll just add to what Elisa said and you know, to what was offered to the administration of a national coverage for Medicaid and Medicare. If we could have that be at those prices for commercial, you'll see more coverage in that space. Thank you.
That's great, Pat. Thank you so much. Melanie, next to you.
Yeah, mine is very similar to what our colleagues in the pharmaceuticals say, that I want obesity as a chronic disease, and thinking of it as other chronic diseases, would want lifestyle implemented just for the whole system as a universal precaution for all chronic disease. So it's not only for obesity. And then I would like to have more resources. I'm lucky at the VA, we have a clinical pharmacist who helps, but when we roll this out of primary care, you know, I think we should have clinical pharmacists helping with titration, and community health workers or peer coaches helping patients navigate and helping us get to the patients who need it most, when some of the stuff could be done with for our support systems as physicians.
Thanks, Melanie. I am on team clinical pharmacist, by the way. Like I am, this comes up in many of our in our reviews, and we have a lot of people in our orbit who do that important work, and so we'll make sure we work that into some of our policy recommendations. Alexa.
I really echo what Melanie said, and I know I'm on a broken record here, but I think supporting primary care to both prevent the development of obesity, and then really provide treatment to this very large population that needs it.
Thank you, Alexa. Joe.
So Sarah, maybe I'll be really specific. I'll take you with your charge. I think I want to challenge our friends both in industry and with our insurance friends and PBMs, et cetera. So let's be as transparent as possible in this process, right? A lot of these conversations we're talking about is, if we had better data and we had better understanding, I think we could come to solutions. But right now, the process, and Sarah, you and I have talked about this and engaged in a lot of these things, like it's pretty opaque, right? Kind of thing. And with that opaqueness comes the doubts and comes the hard part of working through that. And so I know I'm asking us to break the system to do that, but can we find a way to be more transparent about this? Because I based on this conversation, we can find solutions, right? I'm confident actually that that announcement we saw last week is going to translate to large employer plans, right? Kind of things like that. So let's work through this and do this right now. The time is right.
I'm with you, Joe. And if I could editorialize a little bit on that, that's where I'm actually seeing optimism, because I think the announcement from Lilly and Novo last week, I think the way that they're talking about coverage with certain BMIs and I think we're starting to see that opening for this de-escalation that we've been calling for. And I think it's coming from that transparency. And so I'm doubling down on that for sure. Michelle, it's my pleasure to give you the last word. Tell us what to do, Michelle.
No pressure, Sarah.
What's your magic wand telling you?
I think my magic wand is that um, we would truly have an authentic transformation in understanding the comprehensive, complex nature of this disease, and that we wouldn't see it in a monolithic view, but that we would see it truly in the diverse view that it exists in, and that we would act accordingly. And we would responsibly, I will say, that we would responsibly take all of the smoke screens down and look at this for exactly what it is and provide the care that people really need. That's what I would say.
You didn't need my pressure. That was beautifully said, Michelle. Thank you. Thank you. My magic wand is entirely self-serving, which is that I get such a wonderfully engaged and authentic policy roundtable every time I need to moderate one. It is my gratitude is extending to all of you for bringing your best selves to this conversation, centering what we're trying to do, which is increase affordable access to patients, and the optimism that came today is gonna carry me through at least the weekend. And so I thank you all for that and how you participated for that. And so as we wrap up this policy roundtable, I'm going to invite the New England CEPAC to join us back on camera so that Jason can lead us through a final round of reflections from our New England CEPAC from our time together today. Jason, I'm happy to pass it over to you.
Thank you so much, Sarah, and thank you all for a vigorous and informative policy roundtable. So at the end of these sessions, we just go through the CPACs, all the members of the CPAC to offer one sentence of reflection on the day's events. This whole one sentence thing is a legacy of Steve Pearson, the founder of ICER, and has been maintained as Sarah has become the CEO. You can have a semicolon though, so you can go on a little bit. And what I will do is I will close with the same order that I started with the alphabetical order, so we don't miss anyone. Starting by Dr. Azeltine.
Thanks, Jason. This is my last meeting of CPAC, and so instead of a reflection on the day's events, just a little reflection on 16 years of events. This has been it's been really exciting to be a part of this. I would say today's meeting was very, very different, but in some ways left us in a similar place where we applaud innovation while begging for pricing restraint and to have dollars allocated to the system in a way that really improve people's health and make meaningful differences in their lives. And so I just want to encourage ICER and all my colleagues on CPAC to continue the good work and wish you the best.
Rob, thank you so much. And thank you so much for your friendship and collegiality over the years. It's meant so much to me and to many of us. So thank you, Rob.
Thank you.
Austin Fract.
All right, thank you. I just want to commend ICER and all the guests and panelists. Just a tremendously insightful meeting that included really important concepts like cost effectiveness is not cost savings, like you can have cost effectiveness while still having tremendous aggregate budget issues, that there can be cost offsets, but you have to include the cost of the intervention to see what the true cost savings is, along with considering number of needed to treat. That's a big mouthful in a long sentence, but it's really critical to bring all these elements to bear on questions like this, including the clinical issues. Thank you.
Thank you, Austin, and very creative use of semicolons. I appreciate that. Rebecca Kirsch.
Thank you for a very intriguing day. I will finish with my sentence around the quality of evidence and the importance, I think, rose to a new level of importance here of involving patients and caregivers in the development of the quality measures we rely on, especially when we're looking at cost constellations more broadly than just the economics, but what that means for caregivers and for patients. Wonderful day today.
Thank you so much. Steve Kogut, Dr. Steve Kogut.
Thanks. And thanks, Rob, for your service as board chair and everything I've learned from you. And Jason, you as well. Thanks for your service as board chair. I think this is your last one, right? So kudos to you. I thought the policy roundtable was really interesting, sensational. Kudos to everyone who contributed. So great when we have the manufacturers involved. One point I'd make is, when you get payers together and you think about policy and managed care approaches, et cetera, we leave out the uninsured. So I would just encourage everybody to keep the uninsured in their minds for advocacy, and certainly a lot of unmet need there.
Thank you. Don Kreis.
Thank you, Jason, and my congrats to you on your very successful tenure as the leader of the New England CPAC. It's been a pleasure to work with you for a while. I want to use up my one sentence by saying that this is an example of my finishing one of these day-long meetings much more excited and enthusiastic and optimistic than I was at the beginning of the day. At the beginning of the day, I was worried that maybe ICER wasn't really up to the task of figuring out how we can rise to this challenge presented by obesity, given its unique presence in our national culture. And at the end of the day, I feel like we really are all working together to really make sure that these drugs are widely available, and maybe, just maybe, we actually will reduce obesity to a less overwhelming problem than it is today. So thank you. I'm enthused and pleased by especially the very robust and interesting policy roundtable.
Thank you, Don. Julie Coopers, Dr. Coopers.
I agree with what Don said, and thank you to the ICER team and the clinical and patient experts today. The policy roundtable, that was great. It was an amazing discussion, and as a consultant to many self-insured employers, I feel like I've been navigating the conversations around that intersection between affordability and accessibility now for at least the last year. And my hope is that perhaps we will see the prices that are offered to CMS available in the commercial marketplace, which would definitely help increase, I think, affordability, of course, and then access to our folks that need these medications that are clearly very clinically effective. So thank you.
Thank you. Tara, Dr. Lavelle.
Thanks, Jason. And yeah, I really enjoyed this conversation today. And I think I'll just go back to my comment little bit what I mentioned earlier is that I think it's just really important that we not look at these drugs in isolation in terms of the affordability problem. If anything, like these are the real winners of drug development. And this is what we keep asking for, like really valuable drugs that help people. And so these are the winners, and let's not penalize the manufacturers of these drugs because they are reaching such a big population. Let's look at the other drugs, which may be too expensive, and let's try to balance costs in a way that really is going to try to optimize, the health of everyone in this country.
Thank you so much. Kim, Dr. Lenz.
Yeah, thank you to everyone who participated today. Another fantastic meeting led by ICER. I think my takeaway or my magic wand thing would be just again to point out that even when the clinical value is clearly evident, the immediate budget impact is just so substantial here. And as you heard today, it creates a difficult tension between the expanding access to these types of therapies and maintaining fiscal sustainability. So I think moving forward, we need to continue to have thoughtful policy approaches like we heard today, and continue to work with the stakeholders to align coverage decisions that have both clinical value, but also balance that with affordability.
Thank you. Dr. Mitchell, Aaron.
So it also got me thinking about the ICER magic wand and the irony of the magic wand, because usually what the ICER magic wand is wishing for are incredibly effective therapies for conditions that treat a large portion of the population that have high unmet need and miracle, like come in at a fair price. And we can wave our magic wand and get exactly what we wish for, and it still raise enough challenge that we can spend the whole day talking about it.
Thank you. Dr. Vale, Stephanie.
Thank you. Thanks everyone for an informative and inspiring day, and to Rob for your service. You're going to be missed for sure, and Jason for your leadership. I do want to use my time to make another plug for clinical pharmacists. I am biased, of course, but given the overlap with psychiatric conditions and treatments that have potential, psychiatric treatments that have the potential for weight and metabolic effects, I envision with my ICER magic wand that there's both a board-certified ambulatory care pharmacist and a board-certified psychiatric pharmacist in every clinic providing obesity and overweight care. Thank you.
No, thank you. Thank you for the thoughtful comment. Joe Porter.
Yeah, I just want to add my thanks to the ICER team for bringing together a really comprehensive look at this issue, giving us the opportunity to not just think about the value of these particular treatments to the people who have been seeking some sort of care for a really long time, but also thinking about how the broad availability can really change our markets and our systems, which, as we know, if the market fails across the board, access is lost for everybody. So I really appreciate the comprehensive nature of the conversation.
Thank you. Jim, Dr. Ribitzer.
Excuse me. Thank you, everybody, for making my first meeting of ICER such an extraordinarily stimulating event. That's not my sentence. That's thank you. The very careful written presentations and analysis, and the very careful live presentations really changed the way I think about this super difficult issue when you've got a medicine that is both extraordinarily effective and extraordinarily expensive and available to a lot of people. And thank you.
Thank you. Joe Ross, Dr. Ross.
Well, thanks, Jason, and thanks to everybody for an amazing meeting. Really provoking in so many ways to really think through the sort of the challenge of what does affordability mean versus cost effectiveness, and it really, I think, should be pushing us and ICER. When all, as Aaron said, when all of the magic things do come together, but still we have such challenges ahead. How can ICER create a framework that leads us forward? I'm very excited to think about what might happen with CMMI payment models and other steps moving forward, but clearly just because something is priced for cost effectiveness doesn't mean that it's going to be affordable, and we've got to do a better job about that. So anyways, thank you for a great discussion today.
Thank you, Joe. Jason, Dr. Schwartz.
Yeah, thanks to everyone. Setting aside the very real affordability challenges, the benefit and value story here is really exciting, almost too good to be true, and I hope that remains the case. I want to zag slightly and just return to my earlier point about the importance of robust, ongoing efforts to assess these drugs' long-term safety, even if it's just to affirm what looks to be a really good story so far. My work on vaccines and vaccine policy reminds me that when you give products to tens of millions of individuals, we're going to see claims emerging that will allege causal links between these products and serious adverse events. And that day will eventually come for GLP-1s. And so standing up now, the kinds of systems and processes that will let us continuously monitor their safety, respond quickly and rigorously to safety allegations, even if it's just to refute them, I think will be really, really important to the long-term success of these drugs. So thanks very much.
Thank you. And I think I'm the only one left, and I think has been acknowledged by my colleagues. This is my last meeting as chair. So I think for the last time I'm ever able, I'm going to take the discretion to have more than one sentence as the chair for the moment. I am staying on the panel, but I'm not going to be the chair anymore. And I guess and this is part of me being kind of mid-career wistful, is that I'll just go back to recall that this work in this role has not always been easy. In many cases, we've been talking about extremely difficult diseases that cause children to die, things like post-traumatic stress disorder for adults, really, really challenging conversations. And while this work has not always been easy, it has been consistently very meaningful. My first meeting was PCSK9. That was 10 years ago. I was a young cardiologist. I'm no longer a young cardiologist. And PCSK9 was something that was new, but basically no one could get. The price was extremely high, and the payers put up all sorts of barriers. And I'll never know if it was because of our work or something else, but eventually the price came down, coverage became more permissive, and these drugs over time have entered clinical practice in a way that have helped a lot of people. I'm a cardiac intensivist. My work is to see patients commonly at the end of their lives where there's been a lot of missed opportunities in terms of prevention and treatment. So in that setting, this work has not always been easy, but it has been tremendously meaningful. I can't individually thank all the employers of ICER for their collegiality and their friendship over the years, but just know that I'm very grateful to all of you and to Steve Pearson, who founded ICER at the beginning. I really do believe that in a country where 75% of Americans with high blood pressure, the medicines are easy to get. They're cheap. That we're literally just not putting the pills in people's mouths. People can't get primary care doctors. Things aren't well aligned. That we need to continue to advance the value agenda to create a better healthcare system that serves the needs for Americans. So I'm grateful to have the opportunity to take that journey with all of you, and grateful for my continued service on this panel. So thank you.
And as we wrap up today, many of you know that a core value of ICER is starting and ending meetings on time, but I'm going to keep us just a few minutes later, if you'll indulge me on this special occasion, because I need to add my thanks to both Rob and to Jason. Now, we went back and found the original press release announcing Rob joining New England CEPAC as an inaugural member of this panel. And so Rob is our longest serving. Thank you so much for always coming with your best self, bringing such honesty and compassion to the conversation. You will absolutely be missed, but thank you, thank you, thank you. And Jason, you have chaired this panel brilliantly. I know that Steve Kogut is worried because he is stepping into your very big shoes as he takes over as chair next year. But Jason, my deep thanks for your friendship and for your leadership of the New England CEPAC. It's been so wonderful to work with you in that role. And we are so glad that you are staying on as a panel member. So thank you for staying in the family. Thank you, Jason. I think we have one slide, 2 slides up before we get to say goodnight. And again, my thanks to everyone for participating today. I will echo that having both manufacturers bring their creativity and their ideas to this conversation I was just incredibly grateful for that, in addition to the fantastic contributions from the clinical experts, the patients, and the payer representatives. The meeting recording will be posted to the website next week. The final report that will reflect our policy conversation today should be posted on or around December 16th. It will also talk about the votes and the deliberation from earlier today, and everything will be available on our website. With that, it is my distinct pleasure to adjourn this meeting of the New England CEPAC, and I hope everyone has a wonderful night. Thank you.